The next session we're going to have is a board, and for that I would like to introduce Leslie Swanson, who is going to be the moderator. Leslie Swanson is a board-certified nurse practitioner at a UWV Medical Center and Fred Hutchinson Cancer Center and Nursing Advisory Board member. Swanson strives to create active partnership with her patients to achieve the best possible outcomes, and earned her ARNP at Duke. Is a board certified in adult and gerontology primary care. Thank you very much.
Thank you. As part of the Nurse Advisory Board, I am honored to get to introduce our panel of speakers. We have Paige Griffith, who is a certified registered nurse practitioner who serves as an oncology nurse practitioner at Johns Hopkins Hospital with a nursing background and a deep commitment to oncology. Paige strives to deliver compassionate care to patients. Additionally, she chairs the Nursing Advisory Board, collaborating with fellow providers to develop educational resources and supportive care materials for individuals with cholangiocarcinoma and their caregivers globally.
Thank you, Leslie. So to get started, I actually wanted to give you a sneak peek to something that the Nursing Advisory Board's been working on for all patients with cholangiocarcinoma. It's called Cholangiocarcinoma 101. And so this is going to be a resource for patients to have and caregivers that gives an overview of treatment as you're diving into getting started with cholangio what, as Melinda said. So we're going to show the video, and then I'm going to get into my presentation.
Welcome to this introductory video from the Cholangiocarcinoma Foundation and the Nursing Advisory Board. Since 2006, the Cholangiocarcinoma Foundation has evolved into the leading global resource in the research, education, and public awareness of cholangiocarcinoma. This three-part series provides an overview of biliary tract cancers and treatments for patients, family members, and caregivers facing this new and rare diagnosis. It will also introduce some of the resources available on our website, cholangiocarcinoma.org. A cholangiocarcinoma diagnosis can feel overwhelming and leave new patients feeling scared and isolated. So we are here to provide information to help you understand what cholangiocarcinoma is so that you can navigate through your diagnosis, asking the right questions, and leaning on resources that can help you. Let's start with the basics. The biliary tract is a delicate network of ducts that deliver bile from the liver to the gallbladder and then to the small bowel. A cancer can develop anywhere along that system. Biliary tract cancers are divided into subtypes based on the location of the tumor within the liver. Intrahepatic cholangiocarcinomas originate in the small bile ducts within the liver. Extrahepatic cholangiocarcinomas originate in the large bile duct outside of the liver. Perihilar cholangiocarcinomas, also known as Klatskin tumors, form at the meeting point of the major bile ducts that drain out of the liver. Gallbladder cancers form in the gallbladder. Treatment and interventions vary based on the staging and extent of the disease. Although the surgical operations differ based on location, the chemotherapy and immunotherapy treatments are the same for all subtypes. Each subtype is made up of different biomarkers. A biomarker identifies molecular mutations in the tumor. Biomarkers can determine the potential targeted therapy treatment options. Although the causes of biliary tract cancers are not known in about half of affected patients, there are a number of risk factors that have been identified as possible causes. They include primary sclerosing cholangitis, or PSC, obesity, diabetes, hepatitis B and C, alcohol use, and gallstones. If the doctors suspect cancer, a biopsy or a small tissue sample is taken to confirm this diagnosis. Sufficient tissue should be taken to confirm the presence of cancer cells and for additional biomarker testing.
So that was just a sneak peek. The hope is for the Nursing Advisory Board to have many videos to come, but it's a starting place for patients. And fortunately, that video replaces the first few ones of my slides. So hopefully we won't need to go into too much detail. But I'd like to give an overview for patients. I know many people who are here today, it's the first time they've been to this conference, that they've been very newly diagnosed. The treatment landscape is vast, but it's also very unique to everybody. So this is an overview to give you some tools of where to turn to next. So this goes into the subtypes. The incidence of cholangiocarcinoma, specifically intrahepatic cholangiocarcinoma, is rising. These patients previously were typically diagnosed with cancer of unknown primary, or HCC, which was incorrect, and with the use of biopsy and advanced pathology. This has, I think, led to increased diagnosis of intrahepatic cholangiocarcinoma. We went through the risk factors in the video. The initial question that comes up when patients come to our office or our clinics is this patient resectable, or are they not resectable? And that's kind of where the first decision points are made. Technically, resection is the intent of resection is curative. And then we use what we call adjuvant therapy after surgery. And so this can be chemotherapy or sometimes chemotherapy plus radiation. Most patients who present to our clinics are not resectable, but that doesn't mean that they are never curative. But when we're looking at the treatment options, our goal is for possible downstaging. This would be with treatments like chemotherapy or local regional therapies, which we'll get into throughout today. Neoadjuvant means before surgery, and so if you hear the term neoadjuvant, that's what that means. And so other non-curative treatment options, although that doesn't mean that the goal in your mind and in our goal as your providers is not cure. Ultimately, when we think of the treatment options, systemic therapy is when the cancer is typically more advanced and surgery is not possible up front. And also local regional therapies or best supportive care. So most patients, 80% of patients, present in the advanced stage or unresectable stage, which is what we heard last night at the dinner for most patients who were talking about their story. And I think one of the most interesting pieces of information conducted by a large survey done by the CCF is the median time to diagnosis from symptom onset is approximately 19 months. And so this is where community providers, gastroenterologists, and a community outreach through the CCF is critical in shortening that time, because that means time for potential cure. Advocating for your care, I think what's important here is advocating for biomarker testing, as you'll hear a lot about throughout today, and then consultation at high-volume centers that know how to treat cholangiocarcinoma and who are familiar with it. There's many molecular alterations in biliary tract cancers, and like the video said, different subtypes, it's more common. There's lots of small words on this slide, but there's, for example, IDH1 is more common in intrahepatic cholangiocarcinoma, where BRCA or BRCA mutations are more common in extrahepatic and gallbladder cancer. So this is what doctors talk about when knowing the subtype helps us predict potentially what different biomarkers might be involved. So as Dr. LaMarca was talking about first line and second line treatment, what does that mean? First line is the first treatment that we use from a systemic therapy standpoint to treat the cancer. So there's standard of cares, which is what is FDA approved. And in the first line, the standard of care that we use are gemcitabine, cisplatin, and durvalumab. I've heard many of you talk about that, or gemcitabine and cisplatin alone, depending if there's some autoimmune conditions and so on. Not a standard of care, but used occasionally in the first line is gemcitabine, cisplatin, and nab-paclitaxel, which is also called Abraxane. If patients have growth of their tumor or intolerance to those chemotherapies, the providers are talking about second-line therapy. This is not all-inclusive, but second-line therapy for patients who do not have unique biomarkers, which is about 60% of patients, so it's actually the majority, Folfox and 5-FU liposomal irinotecan. Those are some of the options that we use. If you do have notable biomarkers, this is where we see FGFR2 inhibitors, as Dr. Lamarca was talking about. Pemigatinib and futibatinib are the FDA-approved medications here. IDH1 inhibitors, we use ivosidenib. And then if you're MSI or have a high TMB or tumor mutational burden, this is where we use pembrolizumab or Keytruda. Clinical trials are always an option. There are clinical trials in the first line. There's clinical trials in the second line, third line, and so on. And so each time you go down a different treatment, it's first line, second line, third line, and so on. So talking about chemotherapy and its side effects, this could be a 3-hour presentation on its own with each subtype, but I'm going to try to be brief. So gemcitabine and cisplatin and Folfox and 5-FU, those are the main backbones of the chemotherapy we use for cholangiocarcinoma. So there is a lot of overlap between side effects, and so I try to cover them through both. I think fatigue is the overlying side effect that patients have through all of their chemotherapies regardless, and it's cumulative, so it gets harder and harder with each dose of treatment, and many of you can attest to that. Fatigue from the disease itself and from the side effects of the disease, but then also the treatment compounding on top of that. Also common with multiple types of chemotherapy are decreased blood counts, or hematologic toxicities is the fancy word. And we'll go into some of that. Neuropathy, as Melinda had mentioned, diarrhea, constipation, hand-foot syndrome is a little bit more unique to some of the medications, specifically Xeloda, which we use in the adjuvant or after surgery setting. So fatigue management, I would be a millionaire if I knew how to fix fatigue, but it's very challenging. I think my tidbits to patients are getting as much exercise as possible, small bits, even on the hardest days, I think ultimately benefit people in the long run. Modifying your activity. On good days you feel really well, so you want to do all of these activities, but then you wear yourself out and it takes 2 or 3 days to recover. So really modifying your activity, trying to have your caregivers help you manage and limit those so you don't go overboard on the good days. And then adequate nutrition and hydration, of course, which is easier said than done. But again, I think this is where caregivers come in and advocating to try to keep those up. So hematologic toxicity management, this is the blood counts. This is something, unfortunately, that patients don't really have any control of, but I think understanding it is important. So this can be neutropenia or low white blood cell counts. You get your labs checked every week, every other week. What does it mean and why do we do it? So neutropenia, if you have low white blood cells, specifically low neutrophils, this is when you're most at risk for infection. And so often we have to delay the treatment, we have to do dose reductions, and then we add growth factor like Neulasta. Many people probably recognize this little gadget. It's the Neulasta on-body injector, which delivers this medication. I think of these three, neutropenia is probably what is most well known to patients looking at their white blood cell count, because this causes treatment delays, which can be very stressful. You block out your calendar 2 weeks on, 1 week off, 2 weeks on, and when am I going to be done? And then it gets bumped a week, then it gets bumped 2 weeks, and that can be very distressing. So I tell patients up front, expect that treatment delays will happen. We have to reduce the dose. Dose reductions are okay. It's safer for you to have dose reductions, and you're still getting effective medication, but it's important and it's more safe for you, so you don't end up with an infection from neutropenia. Anemia is low red blood cell counts. We can give blood products for that. Thrombocytopenia is low platelet count. Typically, that's not one that we can treat unless your platelets are very low. You're more at risk for bleeding when your platelets are low. And again, treatment delays, dose reductions are what's necessary. So GI side effect management, these are challenging because they can be disease-related or they can be treatment-related. And sometimes it's compounding when it's the two of them together. So GI side effects, in terms of nausea, there are some risk factors. If you're female, you're a young age, depending on the chemo agent that you're getting. If you've had vomiting during prior chemo, these are risk factors to have more nausea associated with your treatment. We recommend small, frequent meals. Ginger chews are very popular and can work well, avoiding spicy meals. Some people use acupressure or acupuncture to help with nausea. We use different medication classes and usually combinations. We've come a very long way with the treatment of chemotherapy-related nausea. You shouldn't be as sick as they were previously in the videos and movies as people anticipate when they start treatment. It's usually a combination of drugs like ondansetron, dexamethasone, which is a steroid, aprepitant, which is a strong, long-lasting anti-nausea medicine. And then we have breakthrough nausea options. Vomiting is not typical. Typically something else is going on if vomiting is occurring, and we recommend that you call your provider if that's persistent. Diarrhea is a popular conversation in my everyday in clinic. What I need from patients to come to me with the information is how much, how often, how many times per day. Are you having additional symptoms? Do you have fever, dizziness, lightheadedness, cramping? The treatment typically is hydration, just to keep you ahead. That's usually what's responsible for the dizziness, lightheadedness if you're very volume down or dehydrated. As a basic, we recommend the brat diet, so bananas, rice, applesauce, and white toast. Also, a little tidbit in here is to hold laxatives if you're using. People are often swinging from one extreme to the other, from diarrhea to constipation and vice versa, and sometimes it's as simple as holding your laxative that you were using for your that you were having for constipation. So, because that will cause diarrhea. So medications, Imodium or loperamide is one that many of you have probably heard of, and there's escalation of that. If that is not working, you need to contact your team because we probably need to use prescription-type medications or assess if something else is going on. Constipation on the other end of that, I have many patients who come in and tell me what their Bristol stool chart number is to be able to assess, how their bowel movements are, keeping track, again, of your last bowel movement, quality and quantity, and for additional symptoms. Abdominal pain, cramping, or acute vomiting, again, can show us that something else might be going on. So potential culprits, many people are on opioids for pain. Those are probably the biggest culprits of causing constipation. The anti-nausea medication, specifically Zofran, is another big culprit. So you're trying to fix one problem, but we create another. And then sometimes cancer causes the blockage. And again, that's one that medication is not going to help treat, so we need to do something else about. Over-the-counter laxatives are what we often use, Miralax, Senna, Colace. I do say that, people are like, oh, I'm certainly on a laxative, I'm on Colace, but actually that's just a stool softener, so it doesn't necessarily make things move, it just makes them soft. So sometimes you need additional supplements, Dulcolax, and then magnesium citrate. It is one of my favorites when we're getting into dire straits, but I put a little bomb symbol because it's just exactly that. But it is over the counter, it's there if you need it. And it's good to have on hand for those emergencies. Again, if you have a constipation that's lasting longer periods of time, you need to talk to your providers. Neurotoxicity is neuropathy is the other word for it. Cisplatin, Abraxane, these are some of the chemotherapies that we use, oxaliplatin, that cause a lot of neuropathy. What's important to tell your providers is when you start to develop neuropathy, because unfortunately we don't have meds that can prevent it. The way we prevent it or reduce it is by lowering the doses of these chemotherapy agents or holding them, because once patients have neuropathy and it's more progressive over time, it's typically permanent. And so we need you to tell us and report to us when that's happening. Again, regular exercise, reducing alcohol intake, avoiding extreme temperatures, and then it often affects your stability, ability to walk, if it's really severe, so using a cane walker, etc. We use some medications if the pain becomes unbearable, or there are some nerve agents that we can use to help the neuropathy. These are things like Cymbalta, nortriptyline, gabapentin, or pregabalin, which is Lyrica, another medication, can be helpful. So it's worth asking about them if you don't see improvement in your neuropathies. Sometimes we do need to use opioids for severe pain. And I do recommend physical therapy, occupational therapy, if you're having challenges with holding things, fine motor skills, walking challenges. Jumping into side effects of the FGFR2 inhibitor, so if you have an FGFR2 mutation, we talked about the medications pemigatinib and futibatinib. These are some of the side effects that we have. Most common that we see, high percentage, is hyperphosphatemia. So this is a blood level, your phosphate level in your blood can be very elevated, and this is a side effect that we know is how the treatment is working on your body. So it's not unexpected. In managing hyperphosphatemia, we check labs more frequently than other types of treatments often. The median time to onset's about 2 weeks, so it may not be right away, but we see it over time, and why we have to keep checking your blood work. We caution you to be aware of high phosphate foods. Of course, in a setting where appetite and taste and all that are altered, sometimes these are the only things people want, so it's hard to modify diet, but being aware of these and trying to reduce these types of foods. Often providers have to add phosphate binder medications. Sevelamer is probably the most common one that we use, and this can help mitigate it, the hyperphosphatemia or high levels of phosphate. If not, sometimes we have to, again, reduce the dose of the drug or hold it. IDH1 inhibitors, about 20% of patients with cholangiocarcinoma have IDH1 mutations, so many people are probably familiar with or will be familiar with this class of drugs, ivosidenib being the drug in this class. It's very well tolerated. I listed out some of the percentages from the trial, but compared to placebo, which is the right side of that chart, a lot of the side effects are probably more related to the cancer than they are to the medicine itself. In general, it's pretty well tolerated. So this is a popular topic, I know, is the Nursing Advisory Board. This is requested frequently, and so this, again, can be an hour in itself, but overviewing the management of stents and drains and what the difference is. So bilirubin is a yellow-colored byproduct of hemoglobin being broken down, the red blood cell being broken down in your body. And when hemoglobin is in high levels, it leads to jaundice. So itching skin, yellow eyes, yellow skin. Often how many people with cholangiocarcinoma are diagnosed. Pale-colored stools, that was mentioned yesterday, dark urine. The risk of having high bilirubin, and why is it a problem? Cholestasis, or blockage, favors bacterial growth in the liver. And this is why many patients who have stents and drains placed have infections or at increased risk of infections, because this buildup of bile there's been bacteria in the bile ducts in the liver, and then it gets released to the bloodstream when you have these procedures, and people get quite sick. Biliary dilation leads to liver damage, so the expansion of these bile ducts, because they're blocked, leads to liver damage to the surrounding tissue if that pressure is not relieved. And then cholestasis affects the liver blood flow. So the point is for the liver to be filtering toxins, and it's not able to do so, which can lead to liver dysfunction. So to fix a blockage, patients initially undergo an ERCP. This is often how we get initial biopsy samples as well. So people have multiple of these. They get very friendly with their GI providers who do ERCPs. And the initial goal is to get a stent internally placed. But if an ERCP isn't able to pass a stent internally, they place what's called percutaneous transhepatic biliary drains. And so you can either have, many patients have one, they have two, they have three. The goal is to try to drain the liver from the outside, which I think is one of the unique but very challenging aspects of cholangiocarcinoma, just the way that these tumors form in the bile ducts of the liver and cause blockage, that this bile not being able to flow. People have all of these drains, which adds an extra component of complication to already a complicated process with chemotherapy, et cetera. So people often ask, what's the difference between a stent, what's the difference and a drain? So stents are typically internal. You can see in the picture on the left that there was a tumor that was compressing that part of the bile duct. They put a stent in and it's able to open it and the flow is able to go through. But those aren't always able to be passed through the tumor if they're too tight with the instruments that the interventional radiology or GI doctors have. So they have to put the stent in, which is an external drain. And again, sometimes it's one, sometimes it's 2+. Stent management is very complicated, and people can have a lot of complications, and this prevents people from ever getting to treatment at some points, which is very hard, or it interrupts treatments and delays it significantly and requires a lot of hospitalization. In terms of management and what patients can do for themselves and caregivers, there's the biliary tract emergency card, which is important to have for this reason. You're monitoring for signs and symptoms of obstruction, which is blockage of that. So this can be increasing bilirubin again, but then also signs and symptoms of infection. So this is rigor, shakes, chills, fevers. These are not unfamiliar symptoms, I bet, to a lot of folks. And so these require flushing if they're external drains, changing the dressing multiple times a week on the outside. Sometimes a bag is attached to drainage, sometimes it's not. And this is very specific to every person and infection and so on. And then these stents and these drains have to be exchanged on a regular basis. There's metal and there's plastic and there's a lot of nuances to this, but you need to be on top of when you've had your drains placed, the dates, and then when they need to be exchanged and so on. And so this is where advocating for your care is important, because not everybody else remembers the dates of yours. And the biliary tract card, I think, is very helpful in tracking that. Let's see. Just acknowledging my team at Hopkins, my mentors, the Cholangiocarcinoma Foundation, and that's it.
Thank you, Paige. Our next speaker is Alexandra Finkel. She is a passionate therapist, educator, speaker, and creator. She is the co-founder of Kind Minds, a space for the hard stuff, providing education, support, and community for individuals and their families during challenging times. She holds a BA in psychology and child development from the University of Wisconsin-Madison, a K-6 teaching certificate from the Relay Graduate School of Education, a master's in social work from Columbia University, and a postmaster certification in child and family therapy from NYU. She is currently receiving her certification in Dr. Becky Kennedy's Good Inside Parent Coaching Program. Allie also serves as a medical content contributor and advisor to Rune, an online platform that offers trusted and expert-created content to help navigate serious health conditions. She has been quoted as a mental health and parenting expert across numerous media outlets such as the New York Times, Healthline, Today, and Huffington Post.
Hi, everyone. I am so incredibly honored to be here today and to hear all of your amazing stories. Speaking to a room full of patients and caregivers, I think, is one of the most privileged experiences a professional can have. So before I even get into anything about grief, and you'll have to excuse me for being out of breath. This baby is pushing on my diaphragm. But you all know grief more than anybody else, and there is nothing more that we can learn from grief than by listening to ourselves and to each other. And so I just want to take a moment for you all to spend just a second thanking yourselves for the strength that you show up with, even in the darkest of days. You're a testament to what strength and courage is, and grief strips us of so much, and grief is ever present in cancer, and that deserves some acknowledgement. So just a moment to turn towards yourself and say, thank you. Thank you for continuing to show up. And to all of the caregivers in this room, you have an equally difficult job, and your grief is different from the person you're sitting next to and caring for, and it is equally valid. Okay. So this presentation, I think, could be like 12 hours, but we'll do it in 15 minutes to the best of our abilities. I hope that you'll be able to think about grief in a little bit of a different way than from before this talk, and identify 3 quick strategies for how to show up for yourself in those really hard moments. A little bit about me. I am a therapist and a social worker. I spent much of my career working with pediatric oncology patients and their families at Weill Cornell Hospital in New York City, and that has informed so much of my training and work in what I do now, which is I see people for therapy and coaching in private practice, which I transitioned to after I had my first baby 3 years ago. I got into this work because as a young teen, my mom was diagnosed with a very rare nerve disorder, which completely changed my family dynamic and who I was as a person. And grief was ever present in my life, which I'll talk about, not because my mother wasn't amazing and isn't amazing, or because I didn't have a wonderful childhood, but because when someone is diagnosed with illness, as you all know, the entire family shifts, and your identity shifts. And I spent many, many, many of my formative years trying to make my grief go away or to pretend that it wasn't there, which left me with subsequent anxiety and guilt for even having it. And so I have dedicated my career to make space for the hard feelings, because they give us information about what we need and how to seek support from others. And grief, in its essence, is about holding multiple emotions at once. And that is what I try and show up for people and teach them how to do. My core values and beliefs that inform my work and who I am and how I live my life are that if it feels hard to you, then it is. It doesn't matter if someone else is going through something harder. It doesn't matter if you think you shouldn't be feeling it or not. If it feels hard, then it is, period. You're not broken. You don't need to be fixed. You need to be supported. And we must seek joy even in our hardest moments because of the fact that life is hard, which all of you know all too well. So, grief. We think of grief often and mostly when we think of death, but that is not what grief is. Grief is the mental, emotional, and physical response to any sort of loss. So if you lose anything that is important to you, then grief will follow. A cancer diagnosis is inherently filled with loss, and some of the losses that catch us most by surprise are those that are the secondary losses. So loss of the person that you were before the diagnosis or before the person that you love was diagnosed, loss of physical capabilities, loss of control, loss of finances, loss of future plans, loss of the security and safety that comes with thinking about the future. And cancer diagnoses elicit anticipatory grief, so grieving a loss before it has actually occurred, and all of these secondary losses, which we are reminded of in the most inconvenient of times, and then traumatic grief and the trauma that exists in going through so much of what you all go through medically. That is trauma, and it must be named. So grief shows up in so many different ways. It shows up physically, it shows up in our thoughts, and it shows up in our emotions and how we act. Grief shows up differently for us depending on how much of a window of tolerance we have for the emotions we're experiencing. So if you're feeling really sick and tired from treatment, then your window of tolerance for some of this is going to be so much smaller. And those are the days where you snap at your partner or your child, or you just feel like you don't have anything to give, and that is okay too. So, 3 practical ways to respond to the grief. Awareness is the biggest tool that we have. Noticing how grief shows up for you in your body and in your life is incredibly powerful, and none of us will grieve the same. Grief is deeply personal. Grief is not a straight line. You are not going to grieve the same way that someone, even if you think that your stories are incredibly similar, will grieve, because you do not have the same background, you do not have the same life experiences, and you do not have the same temperament. Grief is also cumulative. So if you have been grieving before, then a new grief will feel heavier and may trigger old stuff that you haven't experienced in quite some time. So identifying and naming what's coming up for you, and then allowing and validating it. And this may seem so basic and so simple, and yet what I hear over and over again and what I experience in my own life personally is the shoulds. I shouldn't be feeling this way. I should be stronger. I should be happier. I should be more grateful. And those shoulds are judgment versus curiosity. Those shoulds are dismissal versus validation. And so what does validation sound like? That validation sounds like, I'm allowed to be feeling this way. It makes sense that I'm feeling this way. And can I hold the fact that I can feel grateful and also that I can feel scared and that I can feel like this is unfair and I wish this wasn't happening. When in doubt, use regulation tools. So I'm sure all of you have been told, oh, take a deep breath. Breathing obviously does not cure cancer. Breathing does not make hard stuff go away. But breathing regulates the nervous system. And most of us, if we have never learned to take a diaphragmatic breath, do not breathe properly, especially when we need it the most. So I will engage all of you in taking a proper deep breath right now. When our nervous systems sense danger, they go into fight, flight, or freeze. And we see that come up physically, we see that come up relationally. And so actually sending a signal through our breath to our nervous system that in this moment, there is not imminent danger, which of course there are moments where there is, and that is different. But what I'm talking about is the moments where things feel incredibly overwhelming and how am I even gonna get to the next moment? And we do that through our breath. So I always put one hand on my heart so I can actually feel my heart beating, one hand on my belly. And when we breathe in through our nose as much as possible, and then hold, and I'll lead you through this. And then when we breathe out, it's going to be slower than feels comfortable and slower than you think, out through the mouth. When I teach this to kids, I do so using a hot cocoa metaphor. So if you've ever enjoyed a cup of hot cocoa, you can imagine yourself holding the glass and it's too hot yet to sip, but it smells so good. And you take a nice deep breath in, and then you blow it out very gently so as not to spill the marshmallows on top. And so that is a visual that is very helpful for kids, but the adults I work with also tend to like it because it gives something concrete to hold on to. So we'll do it together. We're going to breathe in for 4. We're going to hold for 7, which is going to feel like a long time. And if physically that is not accessible to you right now, that's okay. And then we're going to breathe out through our mouth for 8. You don't need to have more breath to do this. You just have to learn how to pace your breath differently. And you're going to feel as you breathe in, your belly is filling with air. And as you breathe out, it is deflating. And if you can visualize while you're breathing, and if thoughts come into your head, that's normal. Let them go the same way they came, and redirect back to your breathing. But you want to feel strength and hope and calm fill your body with each breath, and you want to feel tension and stress leave your body as you feel your belly rise and fall. So we'll do maybe 2 together, and in through your nose. If you want to close your eyes, that's okay too. 1, 2, 3, 4. Hold. 1, 2, 3, 4, 5, 6, 7, and then we're going to slowly go out. 2, 3, 4, 5, 6, 7, 8. We'll do one more. If that felt hard, remember that all things that we've never done, if you've never done this, feel hard at first. That's not a signal you're doing it wrong. It's a signal that it takes practice. So one more. In. 1, 2, 3, 4, and hold. 4, 5, 6, 7, and then out through your mouth. 1, 2, 3, 4, 5, 6, 7, 8. So I always encourage people to practice breathing when you do not feel like you need it. When you wake up in the morning and you're feeling good, do 5 of those. before bed at night, do 5 of those. We do best with coping skills in moments of distress when we have practiced them in moments of calm. Grounding techniques are also especially helpful in the medical setting when there's so much buzzing and beeping and agitation around you, finding ways to connect to the present and get out of worry or rumination, which is basically worrying about things that have already happened. My favorite way to ground is by something called the color game. And you choose a color. I'm going to go ahead and choose green for the purpose of this demonstration. And you just name everything that you can see in that color. So if I were to do this, I would say, I see the green of your dress and your shirt and your shirt and your shirt, et cetera, et cetera. And you can do this as many times as you need and as many colors as you need. Grounding engages the senses and disrupts worry by bringing us back to the present. And then finally, we must invite joy in. And from even just hearing from all of you this morning, I think that you are experts in doing so. Joy doesn't have to be big, extravagant moments. It is the small stuff. And joy has to be allowed, especially on the days where it feels hardest to access. And so how do we invite joy? If you have trouble kind of moving through those hard moments, I encourage you to get a jar or a box. You can use any sort of box, a tissue box, and I want you to write down in a moment where you can access it, just a number of things, small things that make you smile. So that could be as simple as feeling sunshine on your face, or watching a funny video for 30 seconds, micro moments of peace and of joy, and write them down on little slips of paper, put them in the jar or the box, and in the moments where you're feeling like everything feels bad, after, of course, you've validated those feelings, go ahead and reach into the jar or the box and see if you can challenge yourself to invite that joy in. You can also do this as a family if you have kids. Involving kids in this is a guaranteed way to invite joy in. Kids have a way of teaching us how to come back to what matters most. One of my favorite quotes is that we cannot selectively numb emotions. When we numb the dark, we numb the light. So if pushing away all of the difficult to manage emotions, fear and terror, guilt, shame, embarrassment, sadness, is a way of survival, then that's what you have to do. But in doing so, we actually numb out all of the wonderful emotions that help us move forward. And then finally, I'll share this graphic. So people tend to believe that grief shrinks over time, and I'm sure you all know that it does not. What really happens is that we grow around it. And so instead of thinking of when is this grief going to get smaller for me, when am I going to adjust, and thoughts like that, can we think instead of how much have I grown? And this is not something any of us would ever choose, and yet here we are, and how much all of you have grown if you think about it. I would love to stay connected with all of you. It really is such a privilege and an honor. Most of my work in private practice is seeing people touched by cancer in some way, and every single day I feel lucky to be able to create and hold the space for this very, very, very hard stuff. And every day I feel meaning and purpose, and that is because people like you have the vulnerability to show up for yourselves and for your family, and so I thank you.
Thank you so much, Allie. Our next speaker is Shelby Yaceczko. She is one of few advanced practice registered dietitian nutritionists in California. She holds a master's degree in exercise physiology and is currently finishing her Doctor of Clinical Nutrition Studies. Additionally, she is certified in sport nutrition, transplant nutrition, and nutrition support. Shelby focuses her efforts on providing personalized nutrition therapy in the treatment of complex disease states at UCLA Health, including nutrition for cancer, gastrointestinal surgeries, and improving the general wellness of patients through diet and lifestyle changes. She understands that good nutrition is a catalyst to help you thrive and reach life potential. Shelby is described as passionate, innovative, and firmly believes in the mind-body connection. Throughout her career, she works to empower people of all ages to better understand the power of nutrition and its impact on overall well-being and disease management.
All right, hi everyone and welcome. And if you need a quick stand up to move around and jostle your muscles around, please do. I know it's been a little bit of time since some of us have moved around. I'm truly honored to be here today. Again, my name is Shelby Yaceczko, and I've spent the last decade working in biliary, and pancreatic diseases. This population is so very special to me, and I think sometimes, unfortunately, nutrition gets lost in the shuffle. We can have a diagnosis or a discussion with a life-changing condition, but we often forget that if we don't have the proper fuel, and if we're not eating and nourishing our body, we can't get to the next step. So I'm really grateful to be here today just to share my own experience with working with cholangiocarcinoma and just to kind of remind and show you all what nutrition can do for our bodies. So our agenda today, kind of what I like to do when I'm working with patients is I like to really explain the why behind things. I think sometimes we as providers and clinicians are very good about letting you know the best evidence or letting you know what we recommend, but we don't always do a good job of explaining the why. So I like to really dial down to help people understand what our different organs do in our gastrointestinal tract and how that can matter and make an impact in how we're absorbing and digesting our nutrients, our vitamins, and our minerals. I also want to just briefly touch on nutrition impact symptoms. I know some of these were already discussed previously today, but I'll bring that into the context of what we can do differently with our diet pattern. And then just some general nutrition principles around cancer treatments, as well as surgery. So some key points to note: disease and or treatment can affect appetite and our interest in food. I really can't, I think, name a single patient that has told me their nutrition journey is just smooth sailing. And I'm sure many of you can really relate to that. So nutrition is just as dynamic in many ways as the disease course itself, meaning that things can really alter and ebb and flow. What may work one week may not work the next week, and I don't always have a good explanation for that. So I really, from ground zero, I set that expectation with anyone I'm working with for them to understand, you know, nutrition, what you're tolerating one week or how you're feeling with your energy levels one week may look different depending on your course from a number of different factors. And when we go to the internet, nutrition can be really confusing. There's hundreds and hundreds of blogs and people and providers and some credentialed and some not credentialed, and nutrition is really that space where everyone likes to have a voice. So I do encourage you to explore and learn about nutrition, but make sure we're doing it from credible sources. So that way the interventions and the things that you are doing to nourish your body are truly doing that. They're nourishing your body and empowering you to get stronger and to heal and recover as your body needs it. And we're not necessarily doing things that could be restricting some of our progress. Nutrition in cholangiocarcinoma focuses on really managing symptoms from the condition itself, the disease progress itself, or the treatment. I know we've discussed a number of different treatments that are used with cholangiocarcinoma, thinking things like surgeries, in our medical oncology, looking at our chemotherapies, potentially radiation, et cetera. So what we're doing is, what I like to do when I'm working with patients is we keep a nutrition kind of log that goes along our cancer care continuum. So at time of diagnosis, how are we doing with our nutrition? How are we eating and feeling about it? And then when we create these time points throughout the journey as things may kind of change or we may have different care plans in place, it allows us to figure out what's worked well for us in the past. Because when we have so many things going on, we might not remember that these 3 or 4 meals we used to eat were really nourishing to our body and we felt good. Because that got lost in the shuffle somewhere, because we've been told by providers to not try this or do this differently, or we're tired or we're sleeping more often. So when we have some, documentation along the way, that can really help from a nutrition perspective, bring things back into the mix as we move forward. To keep some variety in as well. Some of our main nutrition goals, maintaining energy and overall well-being. We have to remember that nutrition is part of that mind-body kind of inner circle. Food being fuel and how that can impact things like our mood, our energy, and our ability to move around and stay functional. Eating a balanced diet focused on nutrient-dense foods for fuel. I get a lot of questions on this of what foods should I restrict? What should I not be eating? And I really like to change that mindset of these are the foods we should focus more on. These are the foods that we should be eating more of, rather than the restrictive part. I'm sure nobody in here likes a restriction, and when you top a restriction onto your diet, when diet can be very personal, your diet pattern can be very comforting to you. There's cultural aspects, there's social aspects, there's just personal comfort with food and diet pattern. So when we keep thinking of, oh, you shouldn't be eating this or you shouldn't be doing this, that can feel very devastating too, especially during treatment. So really focusing on what are the things we should include more of. Preventing the loss of muscle mass. So are we moving our body and are we focused? Do we have a plan in place for how we can keep using our muscles to stay strong? We know that different chemotherapies and surgeries and different medication agents can really break down our skeletal muscle mass over time. So that goes hand in hand with good nutrition, maintaining our muscle mass. And maintaining defenses against infection or any kind of potential side effects from treatment. So nutrient metabolism, kind of in a nutshell, and I won't go over all this in detail since this was very nicely discussed in some of the prior presentations and video, but the major function of the bile duct is to move that fluid bile from the liver and gallbladder to that small intestine in the duodenum portion, where it really helps to digest some of the fats in foods. So from my experience, fat tends to be something that can be a little bit more difficult for different individuals during their journeys to be able to really digest and absorb. So what we may do is we might not say you can't have any fats in your foods, which I've had a number of patients come to me and say, I'm on a very low fat diet or I'm really restricting my fats. So we really look at the types of fats, the amount of fats at one time, and how we can spread things out throughout our daytime so we're still getting in good nutrition and good fuel. There's a lot of different types of fat sources out there. Something that's deep fried in a fryer is going to look very different than maybe something that's coming from a nut or seed. So we have to think of where are these things coming from their most natural state, and are we able to tolerate certain amounts of these foods, even if in smaller quantities, to help give us some calories and some energy. As alluded to earlier, cancers can develop in any part of the bile duct. So when I'm working with patients, I think it's very important for you all to understand, where exactly is the cancer and what does that area of my digestion do? Because that can help us understand better as far as what will make sense from an intervention standpoint, or how can we best support you knowing what's going on in your GI tract. And this is very true with surgery. So if there's any liver resections or larger procedures like a Whipple's procedure, these are things we have to consider as far as what's still in there and what's working well, and what may be more compromised, or what's been removed that may be involved in digestion and absorption. So cancer and cancer treatments can lead to what's called nutrition impact symptoms. So I think something that's very helpful is keeping a nutrition impact symptom log. There's different templates online you can even Google and print down, or you can make your own. But this is essentially helping you identify what are you struggling with on your treatment that's impacting your nutrition. And I'll show you some of the examples of the nutrition impact symptoms and how we can combat those or work through some of those. Inadequate nutrition over time can lead to malnutrition. This is a big term, malnutrition. It's not a term that has any positive connotations or outcomes, but we know it's really, really prevalent, meaning a lot of people at some point get some degree of malnutrition, and there's a grading system. Malnutrition is associated with negative outcomes, as well as feeling tired or weak, or the inability to finish cancer treatment or fight infection. There's a lot of research going on in GI cancers right now, and really showing that malnutrition is, we know it's there, we know the prevalence is so high, but we're really not doing a good job of recognizing it early and having plans in place. So meaning that if we're not getting in the energy and the fuel we need, and we're losing weight unintentionally, and our GI symptoms are not being well managed, this can lead to this kind of spiraling picture of more and more malnutrition in an individual, which means we can have worsened outcomes, or we may not be able to have our next treatment due to something like frailty, or we're not able to attend some of our appointments because we're so weak. So these are things we have to really consider too. And nutrition status can worsen if the cancer grows or spreads. I won't go through this, some of the treatment options. Again, this is just as a reminder that when we understand what's working well, or what's compromised, or maybe what organs may have been resected or removed, that helps us figure out what foods and what nutrition may best support our body at this time. So some nutrition considerations if we are undergoing a surgery for our cancer. Some of the things we want to consider after surgery that can happen, so we can have a plan in place and be aware of some of these potential signs and symptoms. Things like motility issues. If our stomach and intestines aren't moving as well as they did before. Things like diabetes risk or high blood sugars. Malabsorption, we're not picking up the foods and digesting it as well. Malnutrition, which I just mentioned. Loss of appetite, or anorexia, where we just really don't have interest in food and we're not ready to eat consistently as we should. Early satiety, or feeling very full quickly. Abdominal comfort, gas or bloating. Altered bowel habits, things like constipation or diarrhea. And even potentially things like pancreatic insufficiency, depending on the location of the cancer and or if we've had surgery, meaning that our pancreas may not be able to secrete enough digestive enzymes, or those enzymes aren't mixing with our food properly. So some nutrition considerations during cancer treatment, and this is just a snippet of what I mentioned for the nutrition impact symptoms. So this is just kind of a very rough guide as far as these are things that can happen that impact someone's ability to eat and drink properly or fuel their body. So loss of appetite. The first thing I say when somebody says, I just don't feel hungry, the first thing I say is, well, what are you interested in eating, or what strikes your fancy today? Honoring those food preferences. Going back and saying, what did I used to enjoy? What are some foods or cuisines that I used to feel really excited about? Making mealtime social. If we're feeling pressured to eat by a loved one, a caretaker, the intention is very much good. right? Eat, 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 you've got to eat. You've got your oncologist, you've got everyone telling you to eat more, but it's frustrating and it can be annoying, to be honest. So I like to step back and say, you know, what are you interested in doing? And if somebody's like, I just don't want to eat, then we work through that. We figure out what are some environments or settings that we can allow you to feel more comfortable and confident in eating more consistently and more frequently. Replacing things like liquid meals with some of our solid meals. Liquids go faster through the tract and make us feel less full than some of our solid foods. Unintentional weight loss. Do we have a plan in place for that malnutrition monitoring? Are we working with a registered dietitian or somebody on your care team? And if not, is there a possibility to? Can we look and see if we can get a consultation to get this addressed? When you're at a visit, there's often so much going on that nutrition's not, sometimes only 1 or 2 minutes, and that's just not enough time in order to really get through and set some goals. Taste or smell changes. We know that the temperatures of foods can produce different odors, which can make taste and smell changes a bit different. So we may look at the temperatures of the foods that we're cooking, as well as the odors from certain foods being offensive in many cases. Things like mouth sores, which can inhibit our ability to have certain textures or different amounts of food. Vomiting or nausea, dry mouth, diarrhea and or constipation. So there are a number of different agents for bowel regimens that can be prescribed, but there's also a lot that can be done through food itself. So 2 kiwis a day for constipation. Actually, there's some studies with the American Gastroenterology Association that 2 kiwis a day can be very much similar to some of the prescribed stool softeners. So there is things through food that can be done. Looking at things like ground flaxseed in the diet pattern or chia seeds. For diarrhea, there's a number of different brat diet is one of the many, but there's also a number of other ways we can think about incorporating more soluble fibers to help the stool and the water kind of bulk up and move through without having so much urgency or potentially so much liquid, watery volume coming out. And a number of other nutrition considerations during treatment as part of this nutrition impact symptom list. This is a fantastic guide. If you have not seen it, I highly encourage you to go back and to download this. It's, I think, over 60 pages, so it has so much knowledge and information, and it's co-authored by a number of dietitians. But it really goes through some different recipe ideas, troubleshooting ideas. This talk today is short, and I can't give you all the information. I wish I could. But go back to find some really credible resources that can help support your own journeys. Some nutrition trends and research to close out. I think it's important to understand where we're at and where we're going. I get asked a lot about prebiotics and probiotic supplements and how we can alter our GI microbiome. The very short answer is we don't know. We don't know right now because every single person in here has a different microbiome, which is basically kind of the bacteria that's housed in your gut. So everyone has different mapping of that, of how much there is and what strains there are. So we're hopeful at some point we'll be able to give better answers as to how we can alter the microbiome to make favorable changes to potentially allow things like treating malnutrition and nutrition status improved. There's a lot of great research coming out in plant-forward diets, meaning that when we're increasing our consumption of fruits and vegetables, that's giving a lot of really great benefits, not only from just eat more fruits and vegetables, but we're getting plant compounds, phenolic compounds, antioxidants, and things that we know can help fight cancer. So I encourage you, if you don't eat a lot of plant foods, please, please, please try to get 3 to 5 a day. All different colors, eat the rainbow. So don't just eat reds, eat greens, yellows, purples, blues. They're gonna give you different properties that will help support your health and well-being. And then lifestyle environment. There's research coming out as far as different lifestyle and environment risks and how we can potentially combat those, hopefully in different ways through some of the food compounds that we take in to fight. And I will go ahead and close off, and I think we'll be doing questions at the end as a panel. Thank you for your time.
I'm going to introduce Karalynne Call. She is a neighbor of mine, and she is a certified nutritionist. She is the founder and CEO of Just Ingredients, a health and wellness company dedicated to inspiring people to live healthier, happier lives. She's recognized as one of Utah's top 10 fastest growing companies. Just Ingredients offers more than 200 nutrition and personal care products made with nourishing, real, natural ingredients. Karalynne has a strong influence on social media and has grown her Instagram community at Just Ingredients to over 1 million people, where she educates about the importance of knowing about the ingredients we put in and on our body. Her top 20 ranking podcast, Just Ingredients, has been a host to nationally renowned experts and doctors who help share the best ingredients for life. Karalynne's passion for mental health, educating others, and creating nourishing products has transformed lives and inspired millions. So when Mark was diagnosed early on, I took a deep dive into nutrition, and I started following Karalynne before she was famous. and then I saw her start doing products, so I've used a lot of those, and I love them. And my staff make fun of me that I'm a healthy eater. But it was important to me, and it is one of the top 3 questions that patients ask us regularly is, how should I be eating? What should I be eating? So thank you. I really appreciate you being here. The other thing is, a couple years ago, we did a survey of about 1,000 cholangiocarcinoma and pancreatic patients, and over 80% of the patients said they had moderate to severe depression. Karalynne has a very unique story, and I wanted her to come here and share that with you because I hope it will really inspire you. What she's built has been amazing, and I think she's helped so many people. I don't know why I'm crying. I love her. Anyway, but I wanted her to come and share her story and share her journey to making things, going from a really hard situation to making things better for other people, and so that we can all be the benefits. So please, Karalynne.
It's an honor to be here, and that was quite the nice introduction. But like she said, I am the mom of 6. Just want to show this picture, and the CEO and founder of Just Ingredients. And I am a mental health advocate, and people wonder what that is. And just last year alone, there were over 7 million people that planned a suicide. It's the second leading cause of death for ages 1 through 44. I will tell my story, but I know suicide and what that entails, and I work with foundations and organizations to educate about mental health and root causes of it, and that there's hope out there for those, and that they're not doomed to this. So I want to tell you a little bit about my story. I'm really glad Melinda told her story about her son, because my story is more for those that are caretakers and family members. But we just heard that so many patients deal with depression also. But what happened was, about 18 years ago, when I had those 3 little boys, we were shocked with the news of my 35-year-old sister that she had stage 4 breast cancer. And she had 4 little kids at the time. And because of the rareness of this breast cancer form, she did a clinical trial that required 16 months of chemo and then 16 months of radiation. Well, she had 4 little kids, and her husband needed to be at work, and so the siblings in the family took a week at a time taking care of her and her 4 little kids, because the chemo, as you know, but her chemo was severe, as many of you have faced, and she was in bed for days and days at a time. And so I took care of her 4 little kids and also took care of my 3 little kids at the same time. But as we were dealing with this, my brother-in-law got a rare form of skin cancer. The oncologist thought it would be fine and it wouldn't be a problem, but some unfortunate circumstances happened with his immune system. He got a staph infection and passed away at the age of 39. He was my husband's best friend, and that took a toll on us. But at the same time, I was trying to deal with my sister, who had stage 4 cancer, and deal with her kids and keep them happy and keep my kids happy and keep my husband happy. But during this entire time, my mom actually was battling brain cancer as well. She was divorced at the time and did not have a spouse, and all the kids had moved out of the house, and so I became one of her main caretakers. Crazy enough, the day of the funeral for my brother-in-law was one day before my mom walked in for brain surgery to get her tumor removed. So as you can imagine, it was a couple years of a lot of stress and worry, and many people forget about the stress and worry of the caretaker and the family member. And so after all this had gone, after I'd gone through all of this, a couple years later, I found myself with really bad depression. And I could not get myself out of this depression. There were days of frustration and anger, but days I didn't want to get out of bed, and days that I had to get out of bed, so I just faked it as much as I could until I could collapse again. People would say to me, "You'll see the light at the end of the tunnel." And I was like, there is no light at the end of the tunnel. This depression is terrible. I can't even function. This is not how I used to be. Something happened. And so I went to doctor after doctor, and doctors were saying, and this was like 17, 18 years ago, so it's completely changed now, but they would say, "We don't know what's wrong." And I went to, like I said, doctor after doctor for 2 years, and they never even took blood work. They never even tried to figure out what was going on inside my body, and I didn't know what was going on. And so finally one day I had it, and I thought, I can't live life like this anymore. Life is miserable. Life is too hard. I can't deal without happiness and hope. I can't do it. And so I actually attempted suicide. And thankfully, by the grace of God, miracles happened, and so the act failed. And so once I'd hit rock bottom, I knew that I needed to go find help, and I was on a new quest to go find help. Thankfully, I found a doctor who was like, "Depression is your body screaming for help. It's just letting you know that something is wrong, and you've gone through trauma, but you've gone through a lot of stress and a lot of worry. I bet you're depleted. I bet your nutrients are just depleted." So we did a lot of blood work and urine tests and saliva tests and different things, and found out a lot of things, but some of the things were like my B12s were very, very low. Well, stress depletes B12. My vitamin D was really low. Again, stress can deplete the your vitamin D. My magnesium was really low. Stress can deplete magnesium. I mean, the list went on and on of things that I was struggling with. My progesterone and estrogen ratios were out of control, or whacked, because my cortisol levels had been so high for a few years of stress and worry of taking care of people. And so I went on a health journey with this doctor for about 18 months, who taught me all about fueling my body properly and how to best fuel it to feel the best that it could. And so now I try to teach others that depression maybe is just your body screaming for help. It can't talk to you, and so let's figure out the root causes. And everybody's root cause is going to be different. No one person's is the same. Otherwise, we wouldn't battle the depression issues that we battle today with people. And so I just have 8 easy little, I don't know about easy, I shouldn't say easy, 8 little steps or things that I like to focus on when teaching people about depression. And one is food, and we've heard so much about food already. B12, it's really hard to feel good without B vitamins, especially folate and B12. So get those greens in, like she already talked about, the fruits and the vegetables. Get those B vitamins in. It's really hard to feel good when we don't have like enough omega-3s. Omega-3s are found in like seeds and nuts and salmon. I mean, you could just put like a tablespoon of chia seeds in your smoothie every day, and that would help raise those omega-3 levels. Fiber is really important, so those fruits and vegetables, again, like she talked about the gut microbiome, fiber is what feeds the good bacteria in the gut. And so many times, like she said, there's all these supplements and all this stuff on the internet, when in reality, whole foods are going to do amazing things to the body, like the fiber that feeds the good bacteria. So getting, like she said, a minimum of just 3 to 5 fruits and vegetables in your day can do a lot of things. Sometimes as caregivers or family members, we're stressed, especially teenagers. that are stressed with the news or dealing with family members with cancer, and sometimes they turn to the sugary, high-processed snacks and desserts and things just for comfort. But in reality, that sugar is creating so much inflammation in the body, and it can degrade some of the amino acids that are needed to build, like serotonin. They're full of processed oils, which can contain a lot of omega-6s. We need omega-6s, but most Americans have way too many omega-6s that are contributing to this inflammation. And so really just focusing on the whole foods, whether they're teenagers or adults or yourself, is really helpful for depression. They're finding that a lot of depression out there is due to nutrient deficiencies. Sleep is another thing that's really hard for caretakers and those that are worrying, because we're trying to get all the little kids in bed if we're taking care of little kids, or the person that's sick is having a hard time sleeping, so then we're trying to care for them during different hours of the night or getting them to sleep. I remember those days of trying to help my sister get to sleep. It's some long nights, some painful nights sometimes, but we need to really prioritize our sleep in any way that we can. A lot of times it's just that we have been on adrenaline all day long trying to care for others, that we need some magnesium at night just to calm that nervous system down a little bit to help us fall asleep. But whatever you can do to help prioritize your sleep and make it a priority, because that is one thing that I missed, is there's sometimes I probably should have asked for help to get those that I was helping with their cancer, help them get to sleep. I should have asked for help because I needed to prioritize my sleep so that I could stay healthy. The next thing is exercise, and we heard about that. It is a great antidepressant for depression, and it's just a little walk. That's all it needs to be. It doesn't need to be some huge thing. And so researchers have found that exercise was able to independently reduce the risk for depression. So just get out, take it 10 minutes away from who you're caregiving for and go outside and walk. The next, sunlight. Like I said, stress really depletes vitamin D, and as caregivers, family members, a lot of times we're indoors, in with them at their bedside, in the bedroom, in the home, in the hospital. We're not outside getting the vitamin D like we need to, and we need to prioritize that as well, to just spend some time out in the sunlight and get that vitamin D. They did a big research study and found that just 30 days had a huge impact on people's vitamin D levels. They also just recently released a new study that they did where they studied hundreds of people and their mineral levels and vitamin levels and things like that, and over 50% of the depressed people were low in vitamin D. And so that is one that is always a huge concern. And we talked about managing the stress, and I was actually going to have you breathe, but we already did that, because people would always say to me, you need to lower your stress. And I was like, how do you lower your stress when you're taking care of people, when you're a busy mom, when you're, doing these things? And I said, but I can learn to manage my stress. And so stress can do more harm to the gut, to your insulin levels, to your microbiome, so many things than toxic foods can. They have some amazing research studies about stress and what it can do to these parts of our body that contribute to our health. And so a free thing that doesn't take very long is like the breathing. Do it while you're in the car. Do it while you're taking care of your person. Meditating has also shown to really calm the nervous system and be more beneficial than even some of the health foods and things. It's amazing, the studies on that as well. And so just remembering that you need to lower your stress, but it's hard to lower it, so to manage your stress. Energy, again, your brain doesn't know the difference between positive and negative. Your brain doesn't know the difference between I can't and I can. And so just trying to start your day, and this goes because this is what happens, well, in my situation. My sister, who was fighting breast cancer, she would be like, I can do this, I am strong, we can do this. But it was never like the caregiver or the kids saying it. And so it's important for the caregivers and the kids or the family members to also say, I am strong, I am capable, I can do this, I can do hard things, I've done difficult things, I will do it again. Giving our brain the positive reaffirmations that we can do it as well. Like I said, your cells, hear the thoughts of your brain, and they're going to hear the negative ones and the positive ones, so why not tell them the positive ones? Connection is really important, but we need to remember it's not just for those battling or dealing with the cancer, but also the family members and the caregivers. They need connection too, and there's actually great groups out there for caregivers, for family members of people dealing with cancer, things like that. And we also talked about this already, but finding joy. It was not a priority of mine when I was taking care of so many people and taking care of my own kids. I didn't even think about it. And really, it just comes down to finding those little simple things that will help increase your neurotransmitters throughout the day. Maybe it's a walk out in the sun. Maybe it's, okay, I'm going to get through this next hour and then go take a nice magnesium soak bath. Maybe it's, okay, I'm going to get all the kids into bed and get whoever I'm taking care of into bed, and then I'm going to journal and write down the things that I'm grateful for, or you're going to read, or whatever it is. But so many of us get so involved in helping that we forget to help ourselves. And so these are just 8 little things that keep in mind that can help you feel better mentally so that you can do better physically to help those that you're helping.
Thank you so much. We've had so many great presentations. I know that we're a little over time, but do we have time to still do a couple questions? Great. We've got some microphones around the room, so if people want to get up and ask questions. We have someone right here in the front. And then we have someone at microphone number 4, if you want to start.
My question was for Alexandria. Was that the social worker? So you mentioned a lot about working with young children. And I know a lot of people, when we talked this morning, have a lot of young children and young grandchildren. And that's what brings them hope and joy. And do you have any talking points or any language or anything that we could use to talk to our young children to help them understand things and to help them learn how to manage their own grief and what that even is?
That's a really great question. It's one of the most common questions that I am asked. People are often afraid to talk to kids about cancer. And the thing about kids is that they notice when things change, and cancer changes everything. And it is not information that scares kids. It is noticing that things are changing and not having anyone reliable or secure give them the information that they need. So it's very normal to feel nervous and overwhelmed about talking to kids about cancer and physical changes and all of that. What kids mostly want to know is, how is this impacting my life, and how am I going to continue to do the things that matter to me, which is not selfish. It is just the way that kids' brains work. So with kids, prioritizing routine as much as possible is so important. Talking with kids about who will take care of them if that's changing. So if their routine is changing in any way and someone new is picking them up, then talking with them, this is what's going to happen while so-and-so goes to the hospital with mom or whoever it might be. So those changes are really important. Talking about what we know and what we don't know. So in cancer, we don't know a lot, and that's really hard. And that is one of the top reasons that people avoid having these hard conversations, because we don't know the answer. Not knowing is okay. And so talking with kids of, this is what we know, this is what we don't know, and And if a kid ever asks a question and you don't know the answer, you can simply say, that's a really good question. I don't know the answer. I'm going to work on getting it. And as soon as I have it, I will come back to you. Kids often internalize, they think that it's their fault. Young kids think they cannot tell the difference between cancer and a common cold or strep or things they bring home from school. So reminding kids that cancer is not contagious, that it's different from being sick. Using the word sick, we actually advise against, and using words that they'll hear or that they'll overhear. So if cancer is being used on the phone or in the home, that's the word that should be used, even with young kids. Talking with kids about the fact that this is hard and that there are many feelings that might come up. With young kids, talking about sadness and confusion and disappointment, right? Kids are often disappointed if a parent or a caregiver or a loved one has less energy. They cannot do the things that they once did. That is something to talk to kids about. That it's not their fault. They couldn't have done anything different if they behaved better, that this wouldn't be happening. These are all things that happen in a kid's mind. So these are all talking points. I actually have an entire workshop on talking to kids about cancer. So if you email me, I'm happy to provide that. But the main things to think about when having these conversations with kids are doing it in a calm environment, that how you say things are more important than what you say, to trust yourself, and that you know your kids better than anybody else. You know that this kid can handle information and this kid maybe needs it delivered in a different way. And to open up conversation, let kids know that they're allowed to ask questions. And with the little ones, expect that you tell them, and then they're going to ask for a snack and not acknowledge anything that you said, and that's okay.
We had another question up here in the front.
Yes, my question is about diet. I pretty much have a good diet, and always did before I was diagnosed, but I eat a lot of fruits. And my kids tell me that I'm eating too much fruit, and even though it's not processed sugar, but it's still sugar, and I do eat a lot of that. So my question is, am I feeding the enemy here and making them feel more comfortable? Because I'm eating so much sugar, so am I feeding the cancer too much?
Yeah, that's a really great question, and that's probably one of the top questions I get, especially at time of diagnosis, is if I eat sugar, if I eat carbohydrates, will my cancer grow or will my cancer spread? And the short answer is that if we stop eating carbohydrates or we stop eating any type of sugar, unfortunately, the cancer does not shrink, the tumors do not shrink, the cancer cells do not die. And that relationship is inverse, meaning that if we eat fruit or we eat different types of sugars, that does not necessarily accelerate or spread the cancer. So it kind of goes back to the big picture of the types of carbohydrates that we're bringing in. So fruit very much is a whole kind of, fundamental type of complex carbohydrate. It's going to have fiber, vitamins, and minerals, so it's good for the body. But there is such thing as too much of anything. So if we were to eat a diet primarily of just fruits, we might be missing out on some of the other components that can help nourish the body. So I like to, things are a little bit relative of I eat a lot of fruit. Does that mean 5 pieces? Does that mean 2 pieces? Does that mean 1 piece? Because that could be different for different people and what their diet patterns are. So generally speaking, 2 to 3 servings or cups of fruits a day is very reasonable for most people, but the goal is that we spread these things out and we're pairing them with other nutrients. So can we have a handful of almonds or something with it, or a different type of nutrient that can help with things like maintaining blood sugar levels a little bit more.
Oh, sorry, back at number 3.
Yes, I just have a simple question. I'd like to know how to proceed. I have a non-resectable intrahepatic tumor, and I have been without treatment for a year. which is a good thing because the tumor is stable. But here's my concern, is that I still have just those yucky symptoms that a lot of you who are in treatment are having. Digestive issues and fatigue continue. So I think I'm going to move on from my medical oncologist who feels like I'm blaming everything on cancer. Maybe I'm just turning into an old lady. But I would just like to know from you experts what you think, what you would do, what type of person you would go to see how I can manage symptoms.
I'm going to give kind of a vague answer to that, but maybe just changing completely some of the routines that you've been doing. Is it seeing a different nutrition? If you've seen a nutritionist, do you see a different one that has some different techniques, doing different types of exercise to try to enhance your energy, fuels? So just, do you make a 180, trying different approaches for your care to see if that makes a difference?
I feel like I've done several 180s and now I'm back to where I began. But so I have done a lot of nutritional adjusting and activity adjusting as well. But I guess my main question is that normal for me to be still having these symptoms with a tumor that is stable and no treatment at this point?
Yeah, and I can pipe in too. Digestive issues, unfortunately, can be very dynamic, meaning they can come and go for anyone, kind of at any time. And sometimes symptoms are alleviated or they're less so, and then other times they're more prominent and they're kind of full rage. So I'd encourage you just to look at your care team. I work very, very closely with our medical oncologists, and I've been able to kind of work in a respectful environment where they know that digestion is not always their expertise. So I would encourage you, if the person who's managing your digestive symptoms don't have a really formal training or history in working with those, then make sure that your care team is set up to properly address things. So in our program at UCLA Health, we're very fortunate. We're the largest GI nutrition program in the country, and we have a subspecialty focus in all GI cancers. And I work very closely with our gastroenterologists who are also trained in GI cancer management. So we co-pair with our medical oncologists and our supportive care team for digestive issues. So we have 4 people for digestive issues. So you can imagine, if there's areas of your care team that you may want to explore, see what options are available, please do that. Sometimes just relying on one person, they can be amazing and an expert in one area, but they may be missing something, or they may not be as experienced in another to support your journey. Yeah.
This is a question from one of our virtual patients. She says, can you expand on the benefits of a healthy microbiome and immunotherapy working better?
Yeah, so some of the research is around kind of like precision nutrition coming out. There's a lot of studies going on with like the NIH right now. We're not there yet, unfortunately, meaning that we don't know what strains and what combinations of different microbiome or CFUs and the different compounds that are out there would be best mixed together, if you will, to help alter microbiome to lead to things like potentially better treatment responses or reduce risks of developing chronic diseases. So I'm hopeful in my lifetime we'll have some better answers, but the goal is we know that diet diversity, meaning that we're eating different types of plant foods and we're eating a diverse diet pattern overall, we're not eating the exact same foods every single day, can contribute to a more diverse microbiome, which can be protective for the immune tract. So I like to encourage everyone I work with, go back to your grocery list, and if you buy the exact same things every single week, we gotta shake it up. And there's a lot of fun ways to do that. MD Anderson has an amazing website called At the Table. It's a nutrition resource page that goes over recipes for symptoms on treatment. The CCF, as I mentioned, has a wonderful nutrition guide. There's a lot of cancer centers that have public websites that you can go on and look at different recipe ideas that can go through things like nausea treatment when you're experiencing diarrhea or some of these other nutrition impact symptoms. And that might just strike you a fancy for you and your caretaker to perhaps put together a new meal with ingredients you may not have used before. I also didn't have time to talk about the importance of spices and herbs, but that is actually one of the best ways that we know right now. Using spices and herbs with your cooking can lead to a more diverse microbiome in your gut bacteria, but also can be very helpful for taste changes you may be experiencing. So use flavors in your food. Don't be shy about it. And it may look different from what your caretaker or loved one is eating. So you might have to flavor your food differently, and there's nothing wrong with that. So the whole point is to enjoy the foods that you're eating, but also knowing that those foods, spices, herbs, and things are fueling your body to help support you.
Okay.
Thank you very much for that great session. So we are now going to move for our lunch break, but before that I have a couple of very important messages for you. First, they would like to take a picture of all the patients, so if you can please all go to the lobby before lunch. They will take all that a picture with everyone there, which is always really, really nice to have. After that, yes, you can go for lunch. That is here across the corridor. Because we are starting again at 1 p.m., those are the bad news, you can take your food and bring it here so we can start on time at 1. And they also asked me to remind you that we have the patient lounge in room 150A, which is a space for you to connect and have some quiet time as well. Thank you.